Again.
Okay, great. We're going to go ahead and get started. We have a little bit of tech difficulties here in Cherry Street Plaza. So I'll be joining from my computer and facilitating. We're still here in the Sue Crystal conference room. We'll just be, we don't have access to the cool little camera that jumps around and follows us and everything, but hopefully everything will still be able to go smoothly. And we'll go ahead and get through the agenda. And so hope everyone is doing well. Let's get started with the typical usual disclaimers. Let me go ahead and share those real quick. We'll go through the disclaimers while people kind of join and start to trickle in. Great. Okay, so hopefully everyone can see my screen. Just a couple of reminders. This meeting is being recorded and live streamed on TVW. It will be shared on the HCA website on the SURSAC meeting page and on our webpage. The meeting recording and meeting materials are open to public disclosure requests, so just a reminder not to share any private or confidential information. Minimize that. And going to the next slide here, our ongoing reminder about using person-centered language, focusing on somebody's experiences as opposed to labels that label them. We have a link here that is always available on our agendas as well, I believe, or at least this document is. And then also just a friendly reminder, if somebody does use stigmatizing language, just use it as an opportunity to engage in a meaningful and helpful conversation about, why that is problematic and can use as a learning opportunity. Guidelines for public feedback. We do have built into the agenda, and hopefully everyone was able to access that. If not, we can get a link into the chat. But we will usually provide time at the beginning of the meeting and near the end of the meeting for public comments. We try to limit that to 3 minutes per person to ensure that there's enough time for everyone to participate and contribute and provide their comments and feedback. And then we also, within the agenda items, we'll be going through multiple topics today. And then what we typically try to do is start with SURSAC committee feedback, and then we'll build into after that time for public feedback as well, throughout the agenda. And then as always, we have our generic inbox where anybody can message, email, or send any sort of questions or follow-up at hcaesb5476@hca.wa.gov. So I'm going to stop sharing my screen. We'll go back to the meeting here. We'll do a quick roll call here to see who we have from the committee. And then I have a couple of quick announcements. And then we'll hopefully get started with our first. Actually, can somebody share the agenda? Yeah. Let's go over the agenda real quick. I want to make sure we have a time just to go over that before and then while we're pulling up the agenda, I'll do the roll call too. Okay. So starting with roll call. Senator Dingra. Senator Braun. Representative Lauren Davis. I can't imagine we're going to have many of our legislative representatives today, but I'll continue. Representative Burnett.
I am here. We'll be cutting out sometime in the next 30 to 60 minutes.
Okay, well, thank you so much for being here. I know you're extremely busy right now. Caleb Banta Green. I saw you, Caleb.
Good morning.
Good morning. Don Julian Saucier.
Good morning.
Good morning. Alexi Orr. Amber Cope. Brandy Flood. Stormy Howell.
Good morning, present.
Hey, good morning. Chad Enright.
Good morning, I'm here.
Hey, good morning, Chad. John Hayden.
Good morning.
Good morning. Nikki Lewis.
Nikki and Sherry are out.
Oh, Nikki and Sherry are out, I've just been told. Hopefully everything's okay with them. James Tillett, I saw you, James, you put your name, put your contact there in the chat. Thanks for being here. Christine Lynch.
Good morning.
Good
Good
morning.
morning.
Hey, good morning, Christine. Sarah Gillard.
Good morning.
Morning, Sarah. Danelle Tanksley. And Malika Lamont.
Present.
Good morning. Addie Adwell.
Present.
Hunter McKim. And a couple alternates, Representative Levitt. And Representative Manjarez.
Yes, I'm here. Thank you.
Oh, great to see you. Thanks for being here. Okay, so we have some pretty good representation today, at least around half, a little bit more than half of the committee present. So thank you all so much for being here. Let's take one quick second and let me just do a time check. All right, we're doing good. Just want to review the agenda today. So as a reminder, we had to postpone the RNP quarterly report because of a couple of competing topics at previous meetings. So we do have Brianna Peterson here to go over the quarterly report for quarter 2 from 2025. So we're a little bit behind there, but looking forward to seeing some at least current information about the Recovery Navigator Program. And then we have a guest joining us, Jessica Blose, our State Opioid Treatment Authority, will be giving an update on Opioid Treatment Program rural expansion. As a reminder, this was a recommendation that came in the Substance Use Recovery Services Plan, so directly tied to what this committee prioritized in terms of the plan that was submitted several years back. And so thank you so much for being here, Jessica, to provide that update. And then we're going to a follow-up from our conversation from last month. Michelle is going to give us an overview and update on how we're approaching the task of identifying exactly which components of the Substance Use Recovery Services Plan are still pending or have been partially implemented or fully implemented or not implemented at all due to lack of funding, lack of policy changes, etc. So a jam-packed agenda today, and I appreciate everyone making time to be here. I do have a couple of really quick updates, and then let me check the chat real quick before jumping into there just to... Oh, Brandy, great. Thanks for being here. Okay, one huge update that this group should be interested about is that the progress report for 2025 was published. So I will drop the link to in the chat for that. I think it was released to the legislature and Office of Financial Management and the governor's office a couple weeks ago, mid-January. And so that is our 2025 progress report, progress made towards implementing the Substance Use Recovery Services Plan, and the information and some updated data and some other great summaries happening there. As a reminder, that's required in the RCW 7124-546, and we submit an annual report on progress made towards implementing the plan. Just a couple of quick words about the government shutdown, and maybe somebody can find the link to our external facing HCA webpage where we have updates, and if not, we'll get that in the notes. But as everyone I'm sure is aware, a partial federal government shutdown did begin. At this time, there are no known impacts to HCA programs or operations, and we do not necessarily expect any immediate funding impacts on the services we provide. Obviously, we're going to closely monitor the situation and communicate if anything changes, and then that communication typically goes out through GovDelivery, or I'm pretty certain we have a web page, an external facing web page where we can include updates about that sort of thing as well as HR1. And so we will get that information into the chat, but obviously thank you to everyone that continues to work and support Washingtonians amidst these sort of uncertainty. Speaking of uncertainty, I feel like I should at least call out what happened back on January 13th when the Substance Abuse Mental Health Services Administration issued termination notices for several discretionary grants nationwide, and some that affected our state as well. I'm pretty sure a lot of you were tracking that. What was interesting when those termination notices came, within 24 hours, they rescinded them. The White House did and announced that the action was rescinded and the federal government intended to reverse those terminations. As of now, we've received all updated notice of awards and everything is moving forward, and there shouldn't have been any lapse in services or efforts happening as a result of those temporary terminations of those discretionary grants from SAMHSA. With that, obviously, incredibly unsettling and definitely impacted a lot of, I guess, ongoing trust and like we don't really know what to expect going forward, but we do have a process in place and a system in place to ensure that we are closely monitoring that, and we'll try to communicate anything in the future if something like that happens again, and ensure that all of our partners are aware of how that sort of action at the federal level can impact our contracts and our relationships with those in Washington State. The link is going to a sign-in portal regarding substance use recovery services plan. Okay, we'll try to get a new link. It should take you, well, let me double check here. Sorry, this is why I usually don't facilitate the meeting from my laptop, because I'll just continue to get distracted by the chat. And so you'll have to apologize, be patient with me throughout the meeting as I try to navigate the meeting in this kind of new format. We will try to get a new link to the 2025 progress report. I swear it was working as of Friday when I was putting together some of these notes. And so we'll get an updated link. Apologies for that.
Tony, it just looks like I have to be like a state employee to access it. It has some little state thing on there. And then when I tried to click that, it just looks like that, like some kind of to protect it. And then also the priority link that you guys just gave us, those are the HR priorities that are impacted by the Medicaid cuts that are coming. Is that what that is?
Yeah, and it will also include any updates on the government shutdown as well. So it's kind of like our legislative relations external facing webpage. We will get the 2025 progress report uploaded onto our SURSAC webpage, and then we'll send out a link. That way it's easily accessible, and then it will be along with the substance use recovery services plan and then the subsequent progress reports as well. So apologies for that. Finally, obviously we are in the midst of legislative session. Hopefully everyone has had a chance to see the first kind of substance use related and behavioral health related bill tracker that we sent out through GovDelivery. As a reminder, that's not to reflect any priorities of the Healthcare Authority, and it's definitely not intended to be exhaustive, complete, or summarize like all of the pending bills that might be of interest to this committee. It's just really intended to be a starting place, and we're trying to be helpful and informative and at least identify which bills relate to or either directly or indirectly to a lot of the conversations we've been having over the past 3-4 years. A couple of quick updates about the timeline for legislative session. Wednesday is the policy committee cutoff date. So that's the last day for either house to read in committee reports and pass those bills out of committee and read them into the record on the floor. We can get, here, let me put this link. Hopefully this link will help. For more information about the cutoff calendars and the timeline for the legislative session, you can visit that link that I dropped in the chat, and hopefully that will be helpful. The list of legislation, I should have mentioned that. Can we have a link to that?
The one that went out with the gov delivery?
Oh, yeah, the one that went out to the gov delivery. Yeah, we can definitely do that. And then I will also we'll try to get out today. I don't know. I was getting, I guess, anxious or excited about the meeting today. So I did kind of put together like this list of some of the executive sessions and public hearings happening this week. There's a lot happening tomorrow and on February 4th. And then we can try to get that sent out with the notes today as well. There's some bills around kratom. There's some bills around endangerment, expanding the endangerment criminal penalty laws to include fentanyl and high synthetic potency opioids. There's the bill around DUI, lowering that down to blood alcohol content to the 0.05. And so we'll try to get that with some of the pending hearings that are happening this week out to the group as well, so that you're kind of aware of some of the actions that are happening in the next couple of days in the legislature with critical legislation that's really tied to a lot of the conversations we've been having over the past several years. I've been talking a lot, rambling. Apologies for that. And I think we are actually eating into time on the agenda for committee member announcements. So I'm going to pause and let Blake take it over and keep us on track and keep us on time so that we make sure that we have time for everything that we have planned today. But it's great to see everyone. And I just realized I completely forgot to introduce myself. And with the tech difficulties and everything, it's just kind of thrown me off my game. My name's Tony Walton, he, him pronouns. I'm a section manager in the Division of Behavioral Health and Recovery, supporting adult substance use and treatment. I'm the chair of this committee, and I believe most of you are probably return attendees, but if I haven't had the chance to meet you or this is your first time attending the meeting, I just wanted to introduce myself.
All right. Thanks, Tony. Good morning, folks. Now is time for any committee member announcements. Anybody want to let us know what's going on with various subjects? Please, committee members, if you want to share, go ahead and virtually raise your hand, and we will give you an opportunity to do so. Any committee members with announcements? All right, last call for announcements. All right, moving on to public comments. We have some time set aside for any public comments. Any member of the public, non-committee member, want to let us know anything, please now go ahead and raise your hand virtually and we'll call on you. All right, again, time for public comment. Any member of the public want to make a comment, please go ahead and raise your hand virtually. Okay, see no hands. Let's go ahead and move on then to the quarterly report. Tony, did you want to add anything before we get to Brianna on the quarterly report?
Yeah, no, I think I kind of briefly teed it up earlier. We are going to just need a couple of minutes to ensure that we have somebody that's ready to kind of share screen. We were kind of talking about how best to do that and facilitate that in this kind of revised environment here. So I'm just going to delay us for a couple of minutes while we are getting ready and getting that kind of situated. First, I just hope everyone had a good week a good weekend and had some time to decompress and do things that bring you joy. I know a lot's been happening around the state, around the nation, around the world, and so just really hope everyone's taking care of yourself out there and doing things that can kind of at least temporarily not distract, but balance out how difficult everything has been. So just wanted to kind of share that, say that, put that out there. And also, again, just thanks for, I know a lot of you are with direct service providers are doing this work in the field. And, you know, we also have a number of administrators out there and program managers, and just this work is so critically important. So just really appreciate that. Okay, let me check with the room. Are we ready to go?
It looks like we are.
Yeah, we can see it. Yeah. Okay, I'm gonna mute. I'll stay on camera so everyone can see me. And then I'm gonna pass over to Brianna Peterson to walk us through the Q2 report for April to June of 2025.
Brianna, are you speaking yet?
Hello, can everybody hear me?
Yeah, we got you now. Thank you.
Okay, awesome. Okay. So good morning, and thank you for being here today and listening to my wonderful presentation about Recovery Navigator Program and our quarterly report. Not only will I be going over Q2 of 2025, as I will also be going over the state fiscal year as we've now reached it with this report, which covers July 1, 2024 to June 30, 2025. This update focuses on referral and outreach activity, case management engagement, and fiscal year trends. It also includes updates on ongoing data improvement work underway across the program. And as with prior reports, the data presented reflects estimated unduplicated individuals. Yeah. So as I was saying, we're going to first go over the referral and outreach data, detailing the response time and program entry points. Next, we'll examine the case management engagement with attention to service intensity and enrollment. And then we will go over the overview of the fiscal year 2025 trends. They will be presented to provide context for quarterly results. Finally, there'll be an update for R&P data workbook initiatives and highlighting forthcoming enhancements to reporting and data consistency. So as we get into Q2, we have 2,635 unduplicated individuals. We had 535 law enforcement referrals from those 2,635. And of those, 637 were enrolled in case management. Our response time within 15 minutes was at 79%. And the top referral reasons, as you can see, are general STD, homeless, mental health, possession, housing, frequent contact with law enforcement, those in crisis, criminal infraction theft, and criminal infraction trespass. These are all based on the individuals in the quarter, as opposed to the number of times that they were referred. So instead of number of events, these numbers are based on the 2,635. Of those individuals in referral and outreach, here's the breakdown for the race distribution and gender. Demographics remain an important tool for monitoring equity, identifying gaps, and informing outreach strategies. We are constantly trying to improve completeness and consistency in this area, and working with our TA folks to provide, documentation and communication out to providers to ensure this as well. Of those individuals in the race distribution, 140 of them identified as Hispanic. Moving on to case management. There was 14,000, over 14,000 case management events with 2,619 estimated unduplicated clients. We had 423 newly enrolled light case management and 214 newly enrolled intensive case management. I have a breakdown like we did previously. So when we look at service intensity, individuals currently enrolled in light case management. Oh, sorry, echo. Sorry. There an echo?
Back. Hey, can everyone hear us now?
We can hear you without an echo.
Okay.
Wonderful. Okay. All right, we're on the room audio now. That way everyone can hear it. And we were jumping around. All right. Thanks for your patience.
Thank you. Okay. So when we're talking about individuals currently enrolled in light case management, we averaged just over 3 documented service events per person, while those in intensive case management averaged about 6 events per person. We are working on better tracking of the connections that we're making, as we have noticed that some were kind of getting missed and may be affecting these numbers. So we are working with providers to ensure that we are capturing all events that occur to assist that individual into recovery or into aid or referrals as needed. The top 5 direct care services are client support services, peer support, recovery, goal support, transportation, and appointments. The top referral to services made were to basic needs, public benefits, housing, SUD referrals, and community support, and to community support organizations. And here is the breakdown for the case management data for individuals. As you can see, our number of refused or not collected is a little bit smaller here, as it was in the previous referral and outreach slide. So we are seeing more rapport and more connection happening in case management, though we would like to see that number kind of shrink a little more down. We do see a big change when it comes to gender identification, which is only at 6% unknown. And now on to the fiscal year 2025 data. So in fiscal year 2025, we had just over 10,000 estimated unduplicated individuals in referral and outreach. We totaled about 15,280 referrals, and of those, just over 2,200 were law enforcement referrals. Our average response time over the entire fiscal year was 72% within 15 minutes. In case management, we had 8,240 estimated unduplicated clients with nearly 60,000 case management events. into the trends. Here is the layout of the entire fiscal year 2025 of the total number of unique individuals per month. Everyone can see I have a very tiny screen, so but it seems like we consistently have some ebbs and flows when it comes to referrals in the referral and outreach tab each throughout the year. These trends, I will say, support ongoing conversations around response time standards, coverage, and any capacity needs with providers and ASOs. Here's the average response times per month that are responded to within 15 minutes. Consistently pretty high, with nearly 70% every month. So we're really good at responding very quickly to when we receive referrals. So really appreciate that from all the providers. Thank you. Like the sound isn't coming very well. Could we mute the room again and just have Brianna? Yeah. Can everybody hear me?
Yeah, we got you without echo.
You can be heard.
Okay. Because I have my volume off too, so I don't know. Should I turn mine back on so I can? Okay. Okay. So we won't hear anybody then? Okay. We'll work in silence. I apologize. We'll switch it and you can answer your questions if you have any. So here's the trend in referral and outreach regarding the top referral reasons. Per month, as you can see, we have general OCD coming out on top, and homeless and general mental health, followed by, housing, frequent contact with law enforcement in crisis, possession, theft, and trespassing. We are working on updating, well, we have updated these in version 7, which I will provide some updates on as well, where we have removed that general SCD so that we can better align with what is actually happening in those referrals. So hopefully we'll, as the year progresses and we implement version 7 in quarter 2, we should have some better data points to see where these referrals are coming from and hopefully be able to report out on those. I
Brianna,
have
we did
some
have
case
one question
management
in the
trends
chat.
about the top
Brianna,
direct client services.
you can't hear us. Okay.
With client support services, peer support, recovery support, transportation, shelter, and appointments being the top trending for 2025. I should probably at some point match up all the years and see how we fare out. That'd be interesting to see how we've done over the years. And the last one that I have here. Okay. And the last one we have here is the just some trend lines of the number of light case management participants, intensive case management participants, and the overall case management events that occurred. And the last is an update for the RNP data work group. So as always, we're consistently looking at process improvement efforts regarding data collection and counts. We're now focusing on moving towards the updated version, another updated version of the data dashboard that should be public facing. We are working on developing that out, especially now that version workbook 7 is wrapping up and getting implemented as of April 1, 2026 is when we'll start using that workbook. So majority of that work is kind of just coming to an end as we put that go live date ready to go. But we'll start turning our efforts into that public facing dashboard. I know we've talked about this many times. So it's not currently available for the public just yet. As we've been working through this data workbook, we found some issues with, how we count individuals, what kind of data points we're reporting out on. So we're working on just revamping the entire thing and making it reasonable and feasible for others to see as well. So we're working with the CQCT, which is the Clinical Quality and Care Transformation Team, along with the Research and Data Analysis Team, RDA at DSHS, along with our, program leadership and other data analysts that we've been working with to ensure that, everything is properly formulated and ready for public consumption. So as I was saying, the data workbook version 7, it is now with all the ASOs and providers to start updating the EHR systems. We are finalizing the documentation, the supportive documentation that will go along with those workbooks. That is currently out for review with a couple individuals, and as soon as those are ready to go, it will be sent to our communications to be made public. So those will be on the RNP webpage on hca.wa.gov, and everybody will be able to see them. And yes, again, version workbook 7 will be implemented April 1, 2026. So that'll be the starting that quarter 2. So we probably won't see that data until the end of the year or beginning of next. We'll try to squeeze in as many as we can of these reports in the meantime, so we can get to that by the end of the year and get that first one out to you guys. I see some questions, so I'm gonna take questions. Okay. Go.
Okay, all right, we're back in the all-room audio capability mode. So thank you for your patience for that. Blake, we did see you go on camera and trying to say something. Sorry we didn't hear you.
No worries. Slide 10, I think that was a reference. Caleb had a question about 15 minutes response time. What exactly is 15-minute response time? Some returns a phone call or something else. You see that in the chat?
Yeah, so Brianna, do you want to take that?
So when RNP was first formulated, there was some requirements about response times to be timely. And so we developed out some response times in the original UPS, I believe, that responses were within, 45 minutes. I think more so if you were in rural areas, I think it was up to 60. But it was, responding to those referrals either from law enforcement or from, community organizations or wherever those came from. But being able to respond to them in a timely manner. Sometimes that's in person, the person's, being met where they're at, or it is, they got a phone number from the individual and they gave that person a call. And that's that initial contact. So we typically like for those responses to be as quickly as possible. So we do capture if they've been completed within a timely manner. And we've just noticed that they've consistently been, so our reporting out was, if they've completed it within 15 minutes or not.
Okay.
Answer your questions.
Caleb, did you get your answer?
Kind of. I mean, some point it'd be interesting to sort of get a little more breakdown on that, what that means, right? It's one thing to have sort of a quick initial phone call when it's for something a little more substantive. So just be helpful at some point if there's any richer data. There may not be, but there's yeah, that can be a lot of different things. So I'm curious about that. Moving on to my next question. Other questions I had were among those folks with either opioid use disorder, alcohol use disorder, do you have information? Are you able to link to the proportion who ended up getting prescribed treatment medications?
Yeah, great questions. Unfortunately, that would require some level of cross-database analysis where we would have to basically take the identifying information for the Recovery Navigator Program participants and link them to our Medicaid claims data to be able to identify to what extent there's OUD diagnosis happening in the first place with that population, and if it happened after their date of enrollment, and then cross-reference that list with, I mean, you know how all that, the amount of background work that it takes to be able to do that sort of sub-analysis, and we just don't have resources. And staff time is limited. We don't have funding to contract with RDA or an external party to do it. We could do that internally at the healthcare authority to some extent. Oh, I don't know why I'm looking at that camera. It's not even on. We could do that within the healthcare authority to some extent, but as a reminder, we had to reduce our overall budget 6% for the biennium, and so staff positions have been cut. We've had hiring freezes since December of 2023, 2024 maybe, 2024. And so great questions, ones that we're thinking about as well. And what we can commit to today at least, is bringing that back to the R&P data work group and maybe coming up with a timeline to be able to say, hey, this is something that the committee has identified as of importance for this group, for this population, and then try to come up with some sort of game plan while prioritizing other, outstanding work that our data team has. And so, good questions, and we'll see what we can do.
Yeah, and I completely get all of those things. I appreciate that, and we'll just note that, per SB 6228, as well as just generally understanding the actual impact, that would be a pretty important measure. I know you know that, but I just want to say it out loud. Thanks.
No, absolutely.
All right. Just some notes from others in there to pick up. I think Teresa got her question, or at least we'll let her know that is not available yet. Any other questions from committee members?
Just wanted to point out Susan PC's comment, that the definitions are different across teams and across regions. I think for the most part, that's pretty accurate. And that's in response to the question about what does it mean to have a response within 15 minutes? 15 minutes response time. Is that answering a phone call, calling someone back, responding to a web-based form that was submitted, or actually seeing the person in person and having some level of engagement? We will have to just kind of double check and see what the criteria were within the uniform program standards and kind of what the expectations were about that response time. But I think for the most part, it's any sort of engagement, any level of engagement, whether it's a phone call, outreach, calling somebody, or actually meeting somebody in person in the field. So Susan, thanks for sharing that perspective from King County.
All right. Any other questions regarding our quarterly report here? From anybody?
No. Real quick, while the committee, any committee members are thinking of questions they have, one thing I wanted to just kind of throw out there is, that was Q2 of calendar year 2025. So we still have Q3 3 of calendar year 2025 and quarter 4. So basically a half year of data that we want to bring to the committee. And one thing we were trying to discuss and trying to understand, what the committee would prefer is if we bring that as like a 6-month data set, or if we bring it like in a quarter at a time, like we've historically done. As a reminder, we just got a little behind on these updates because of prioritizing other conversations around involuntary treatment and substance use disorder, and some of those kind of ongoing conversations that we had, bless you, at the end of last year. And so if there's no preference, we'll figure out what works best within like kind of the agenda time that we have, and other items for discussion for the next following months. But just wanted to kind of see if there's any preference one way or another. And I mean, we could even wait until we have all of state fiscal year 26 and come back and look at the entire state fiscal year, 4 quarters of data later on this year, like towards like fall, like towards the end of our meetings, So if anyone has any kind of strong preference one way or another about how best to receive that information, we'll continue to just do it quarterly like we've been doing. And otherwise reach out to Brianna or the mailbox or Michelle, and we can try to bring this information in a way that's helpful and useful and makes the best use of everyone's time.
All right.
Did we open it up for public comment?
We did. We just did. So any other questions from anyone out there on the quarterly report?
Brianna, thank you so much. And thanks for winding through all of the tech difficulties. Appreciate that.
All right. So it looks like we don't have any other comments or questions or comments. So I think maybe we move on. Tony, do you want to talk about the service plan update and introduce Jessica?
Yeah, absolutely. Okay, Jessica is here. I know we're a little ahead of schedule. So Jessica, maybe if you can confirm that going now works. Otherwise, we could take a 5-minute break and come and circle back around in 5 minutes.
Yeah, I can do a quick test. Can everyone hear me for when we come back?
We can hear you.
Awesome.
Okay, so Jessica, if you're okay with going now, we could just go ahead and jump right into it.
I would say it's up for whoever anyone would like. If you all would like a break, we could take a break. I'm also happy to go straight into it.
Well, we've never given this group breaks before, so I don't see why we should start now.
All right. All right, then.
There's just always so much to talk about. But Jessica, I'll let you introduce yourself. Just wanted to extend appreciation for all the work that you do and your team does around opioid treatment programs and expanding access to methadone resources in the state. And thank you so much for being here.
Yeah, thank you. And thank you everyone for having me. I'm so excited to be back here today to talking with everyone with the SURSAC committee. There's been a huge amount of growth and progress specifically with opiate treatment programs. And a lot of it does have to do with certain recommendations that came from the SURSAC plan a few years ago. So I am going to experiment with the screen sharing process. Give me just one moment. Let's see. Let's see if this is working. Awesome. All right. Does it look like the correct type of screen for everyone? Probably.
Looks good.
Okay. So again, I'm Jessica Blose. I am very fortunate to be our state's Opiate Treatment Authority. This is a role that every U.S. state and territory has, where the federal and state government identifies one person as having oversight over all opiate treatment that's done with an opiate agonist medication. in an OTP setting. So I am that person for our state. And, let's start off with some level setting. When we're talking today about opiate treatment programs, we are not talking about buprenorphine prescribing. We are specifically talking about what's legally known as an opiate treatment program. It's also what has historically been referred to as the state's methadone clinics. Although we don't like to call them methadone clinics anymore because they do more than just offer methadone. But that is one of the major things about them. They are considered legally a licensed behavioral health agency subtype in our state. All opiate treatment programs in our state offer counseling and medical services to any of the patients that attend. They're all truly kind of integrated care settings, and they happen to have a treatment team that includes medical prescribers like doctors, could be physician assistants, ARNP, nurses, practitioners, also LPNs, RNs, counselors, some have peers. And it is the only type of outpatient setting where methadone, which is one of the FDA-approved medications to treat opiate use disorder, can be offered. So basically, if a patient needs methadone, for the most part, they're going to one of our state's opiate treatment programs. And the other thing to know about these settings, again, is this is not about prescribing or prescriptions. Every single OTP actually has a form of a pharmacy dispensary that is literally within the facility that is managed by usually nurses. Sometimes there might be a PharmD helping out. But the medication is administered or dispensed directly from the facility. And it is not like, again, what we're usually talking about in other settings where buprenorphine is being prescribed and then filled at a community pharmacy. So I think it's always helpful to just ground this because we talk so much about buprenorphine in our state that when we're talking about today, again, is something that is different. Also, we're going to be talking today about medication units, OTP medication units. That's what the opioid treatment program is. So there are now, under federal law, a couple of different ways that you can have an opiate treatment program. There's what we're calling like a baseline brick and mortar opiate treatment program, which is basically your traditional OTP. It's a big standalone facility, but there are also now the ability to have satellite versions of OTPs, so essentially like mini OTPs that can be out in the community. Today, we're going to be talking about two different kinds. There's a mobile kind that is literally an OTP dispensary that travels around in like a medical van or a medical bus. And it is a vehicle. It looks a lot of times like a RV type of a situation. If anyone has ever seen like mobile mammography or mobile dental or mobile medical, it's just like that, except for there's also a DEA graded safe within the van, and it literally carries around the medication with it every day and stops off, and they'll dose people in different communities across the state. There is also another satellite clinic type setting called fixed site medication units that have only been allowable in our state since around February or March of 2025. So just within the last year. And they can be either standalone, so like a small satellite clinic that is not as large usually as like a traditional OTP, or very coolly, it can be co-located within a secondary setting. So theoretically, if a hospital system wants to have a mini OTP, they could co-locate one of these fixed site medication units. There are primary care settings, FQHCs, community pharmacies. Other states are putting some in urgent cares. You could theoretically have a mini OTP co-located within another healthcare facility that's primary purpose is not to do methadone. So again, spending a bit of time on definitions because we're going to be talking about all of these things. And I guess I'm going to try and make this a little bit interactive. Does anyone have any questions before we kind of jump into the bulk of the presentation, all the cool updates? Caleb.
I've not had that much coffee today, just so folks know. It's just my normal number of questions. You've explained this to me before, Jessica, but I want to make sure I understand it and other people understand it. So, the medication unit, I guess my one of my questions is, are they allowed to initiate or start a person on methadone or just maintain them? And I forgot the second part, so there you go.
So, originally they were only meant to continue folks who had already been initiated at a brick and mortar site. However, though, the federal government has also changed the rules for opioid treatment programs and now allows telehealth, audio visual, the ability to like initiate patients remotely. And in a lot of ways, that's kind of now blurred the lines between the two sites, because if an OTP provider has the capacity to offer audio visual, like telehealth initiations, then now basically any setting can initiate and any setting can continue. And it's really a matter of more just where these programs are, and also the ability to do telehealth for counseling and other services. It's again, in a way, it's kind of made a lot of the other things irrelevant. So,
And one other quick thing, are there the same sort of infrastructure requirements, particularly issues around the safety and securing of the methadone in terms of the types of safe and dispensing windows that I know have been problematic over the decades? In other situations where I've been trying to expand that, there's some infrastructure stuff that can be kind of cumbersome. Thanks.
yes, so all opiate treatment programs have that dispensary on site. That is the key element of all of the siting types we're talking about today. They all literally have a dispensary within the thing. It's just a matter of how big that dispensary is, how many dosing windows they might have. The medication unit sites oftentimes are only going to have one dosing window and a much smaller safe than a normal site, which might have 4 to 6 dosing windows, and then like a large, what you would think of like a pharmacy when you go to your local community pharmacy in spaciousness. But yes, they are all still regulated by the DEA and the Washington State Pharmacy Commission, and basically they have to meet the same types of requirements. They're all still alarmed with automatic alerts to local law enforcement. They all have to have DEA grade safes that are like cemented into the vehicle and things like that. So in some ways, it is still a higher cost setting to operate because there are so many additional infrastructure and costs related to operating them for the safety piece. Any other questions all before we kind of move along? Okay. So let us talk about the recommendations from several years ago. There were 5 sub-recommendations under the original recommendation 15 in the SURSAC plan. So one of the very first recommendations was that the state should create a regulatory process to allow for off-site medication units. At the time of SURSAC, DOH was already working on the mobile medication unit piece, but nationally and federally, there had always been this ability to have these fixed site medication units. But the reality is they had only really operated in like 3 or 4 states out of the whole country. And the Washington State Department of Health at that time didn't have a process for doing it because historically no OTPs had ever asked about it. However, with the recommendation from SURSAC, it helped to support, as well as stakeholder feedback from the OTP providers. Our Department of Health back by January 31st, 2025, successfully did change the WAC in our state to allow for OTPs to register and cite fixed site medication units. So we have the language here. Basically, all of these sites have to comply with all the federal rules for them, as well as, and I'm happy to say we actually already, since this January 31st, 2025, we already have one of our very first fixed site medication units, the smaller satellite OTP that is opening in Port Orchard, Washington. So they are successfully licensed, and we have at least 3 other fixed site medication units that are in the queue with Department of Health waiting to be reviewed and approved as soon as they can meet requirements that are there under state and federal law. So in the context of SURSAC, all of these sites, I mean, maybe Port Orchard a little bit, but the other 3 sites that are proposed right now are not necessarily rural areas, and none of them are co-located within another healthcare facility, so they are all standalone proposed sites at this time. But there are also a huge number of other providers asking about this, and even without naming any names, one of the state's biggest county jails is trying to evaluate and has been talking with us and other OTP providers about the possibility of putting a fixed site medication unit in one of their carceral facilities. So I will pause there, but basically how it's going, this specific sub recommendation pretty much has been fully implemented and is alive and well and resulting in new provider sites across the state. Any questions about this one at all? Malika.
Thank you, Jessica, for sharing all these updates with us. It's heartening in the midst of, so the distress that a lot of us find ourselves in nowadays. I do wonder though, what is the potential for more rural locations?
Great question. I think some of the other items that we'll be talking about will hopefully touch upon this, because were also recommendations about how we could expand into rural areas specifically. So I might say stay tuned a little bit, but then also I do want to be clear, a lot of the expansion that is being driven is either coming directly from the private sector, and by that I mean for-profit or nonprofit OTPs that are wanting to expand in different areas. And then also a lot of the growth in our state is occurring from our tribal partners, because Washington state tribes owning and operating a significant numbers of the OTPs in our state. These tribal governments are also leading a lot of the expansion that is happening into rural areas. But we do have state funding that we have directed specifically at rural areas that I'm going to be recapping real shortly. And then there's even some information I think will be helpful for this group to think about maybe potential next steps. A good question. Any other questions before I continue on? Okay. Well, I think this slide is just meant to show, right? Department of Health has a really awesome website that is like kind of nationally known at this point for the type of TA it can give to OTPs. And it talks about, here's a fixed site medication unit, here's how providers can apply for it, all the regulations, contact information, FAQ. And again, a lot of other states have actually been reaching out to DOH to try and have a similar process in their state. Well, let's talk about the second sub recommendation. We also, several years ago, worked, with SURSAC, and it came up with this recommendation to ensure that the OTP branch sites of all kind, this could be the brick and mortar, the mobile, the fixed site, all should be clearly seen as essential public facilities. And the goal of this was to prevent them from being zoned out or stalled out by city or county legislative authorities that might be putting up moratoriums on these settings. So how is it going? We are making a ton of progress in this area. Basically, 5536 from several years ago established that opiate treatment programs and their satellite sites, so again, fixed site medication unit and mobile, all needed to be considered essential public facilities in regarding to the comprehensive planning of each city and county. This meant that all cities and counties already have to have an ability to identify and cite essential public facilities. And now it basically created a requirement that OTPs, again, of all kind, have to be included in that. So this is visually horrible looking, I apologize, but basically this is the RCW 3670A 200, and it was adapted, and this part highlighted shows for essential public facilities, OTPs and their mobile and fixed site units are now in this category. Other things, how it's going. My team, because we help support the opiate treatment programs, represent the healthcare authority, and we have the good fortune, we meet every month with the civil rights team from the Attorney General's office here in our state. And we're always discussing instances of both patient discrimination, OTPs, but then also provider sites. So we have been coordinating with the Attorney General's office anytime we get a report around a city or county legislative authority or perhaps their planning commission that we hear there might be improper zoning requirements or zoning moratoriums that are specifically being put in place. Another cool thing is we actually have the ability and latitude to directly meet with cities and counties. So I can even reference, we have met with City of Walla Walla, City of Wenatchee, and the City of Puyallup all within 2025 to talk with them about there are proposed OTPs that wanted to expand in their city limits, and there were specifically requirements or limitations that seem to be on the books that would maybe prevent that, or furthermore, that could be inadvertently not being in compliance with the Essential Public Facilities Act, or basically treating an OTP in a way that they're not treating other healthcare facilities, which is ultimately the goal, right? Any local jurisdiction, city or county legislative authority can put a conditional use requirement on a site, but we want it to be no different than a conditional use requirement that would be there for any medical setting. So we have successfully petitioned at least 2 of those 3 cities to voluntarily change their processes to allow OTP expansion into Wenatchee and Walla Walla, which we'll be talking about more. But I did want to raise this as like I'm marking some of these slides as a quality improvement opportunity. Even though we have this essential public facility requirement, and even though we've added OTPs to it, we're still finding a huge amount of city and county legislative authorities still seeking to just zone out opiate treatment programs and their medication units, or also just not really understanding what either an OTP is, and or even understanding the Essential Public Facilities Act. Some cities and counties have come back and said, now we need to actually hold the proposed OTPs to the highest level of review, because there is this RCW that says there is an essential public facility, meaning we need to scrutinize them even more than before. Other places have reached out and said, like, well, if it's a mobile OTP, should we just zone it like we do an ice cream truck? Because it's like driving around and carrying around things like an ice cream truck, which is clearly like, these are, again, more like other mobile medical settings, not ice cream trucks. So we just wanted to highlight this for attention with the SURSAC committee. Again, we're making a lot of progress. The Essential Public Facility RCW has ultimately been helpful, but it still feels like we're having a lot of questions, confusion, and it hasn't always been as 100% successful that I think a lot of us thought it would be for trying to address this issue. But I'm going to pause here because maybe this one would want to generate a little bit of questions or conversation. Any questions or comments? Malika.
So, what do you feel like the options are as far as to improve the likelihood of, having less barriers to increasing access to treatment?
I'm going to jump ahead for a moment. One of the other recommendations that was in the SURSAC plan, it talked about how there used to be requirements that the Department of Health would have to have a special kind of like a public hearing in local areas to talk about the OTP and to receive feedback. But basically, as long as the OTP provider met all requirements, the DOH would approve them. So the SURSAC committee several years ago recommended removing that public hearing process, but then also the recommendations from SURSAC came to this part here, allocating resources to support things like public education, community engagement opportunities that could center and protect OTP patients, prospective patients, trying to reduce stigma and share evidence-based outcomes related to OTPs. And, you know, one of the recommendations we are bringing up is, yes, we have been able to change things, and now Department of Health no longer has a traditional public hearing like it had before. There is still a community notice. But then another quality improvement opportunity that I had noted is again, local city and county legislative authorities still seem to struggle, just like with lack of knowledge of like what is an OTP, what are the state requirements for zoning. And it just feels like this lack of knowledge makes the existing state requirements less effective. And I think an area that could possibly be considered is there was never, though, even though there's this great SURSAC recommendation, there was really never any funding or directives issued to any state agency by the legislature to try and allocate resources to do more like education and engagement with the elected officials that in maybe cities and counties statewide. Like we've talked about, can we present like the Association of Cities and Counties upcoming like annual conferences to get more information out there? But like if there maybe had been some resources that could have been allocated or direction to different state agencies to how to both educate communities as a whole and maybe like local businesses and other important parts of a community, as well as how to just provide information and education to city and county legislative authorities. Maybe that would be an effective strategy. And again, also in alignment with something that SURSAC had recommended way back in 2023, but then this specific piece never really seemed to take off. And I will pause there. I don't know if that's helpful. And I see Richard's hand is up.
Yeah, Jessica, if we have any community members with questions, we'll take those first, and then we'll get to Richard. So, any community members with questions at this point of pause? Okay, Richard, go ahead.
Well, thank you. So let me put my hand down. So I guess I stigmatized stigmatism in terms of what that actually means, because when I heard stigmatism, especially with OTP, I was thinking of the general public at large and how to educate neighbors of the standalone or what's the plan to address? I'm kind of shocked hearing that city legislatures, county legislators would be the barrier to access of this service to the community. So what's the plan to address that stigmatism coming from interstate legislators, and that they're not on board with this? So if that makes sense with that question.
So again, I think my team at the state level only becomes aware of concerns when there is an OTP that's wanting to expand into like a new area, and the OTP provider goes and communicates with the local legislative authorities to obtain like, you know, business permits and other types of permits and like to comply with any local zoning requirements as any healthcare organization would, and they find out there's some kind of a barrier. At that point, right now, the only real process is basically almost like a whack-a-mole type response where we will find out about an issue, and then we will proactively, again, talk with the local attorney general, or I'm sorry, our state attorney general's office and get some feedback. And then our SOTA team will reach out to usually like the city manager, the planning commission, or elected officials and talk with anyone who's willing to try and share information, answer questions, and to let them know that also, in addition to the essential public facilities, RCW, opiate treatment programs and all SUD treatment is protected under like the ADA and WLAD, which is the Washington State version of the ADA. And these are considered like disabled individuals who need treatment, and also if they have zoning that is maybe not supportive of SUD patients getting their care, that they might actually also be at risk of discriminating against folks with their zoning, and it being a bigger issue where you're also now violating the ADA and WLAD. So usually at that point, again, most cities and counties are like, no, we are absolutely not discriminating against folks. And again, voluntarily, many places will change their policies, and then the OTPs have been able to expand in those areas. Also, OTP providers will like invite city and county elected officials to come and tour an OTP to see it with their own eyes, because there, right, can be a lot of just misinformation or lack of information. But this whack-a-mole kind of approach is also maybe not very proactive, or it's hard to find, again, capacity to find a way to educate like the whole of the state, or again, what are the best opportunities to try and educate large numbers of cities and county legislative authorities at the same time. And again, we wanted to bring this up because we are not sure what could be the best approach for that, other than knowing that there's clearly a need and we want to see more methadone access and saturation in the state. And some of the concerns that are coming up are in places that would be more considered like rural, in parts of central and eastern Washington that ultimately, like, they have never had an OTP. So why would local authorities understand what a methadone clinic is? And it is a kind of a confusing setting because it's so heavily regulated. So I know it's a really long answer. I'm not sure what are some of the best things that could be done, but just wanting to highlight this is an existing problem. It's a continuing problem. And if there are ways that we could be more proactive, our team is open to that feedback, but then also wanting to raise it here in case the SURSAC committee would want to do anything with this information.
Thank you.
For time's sake, I'm going to continue to move forward. Another quick thing, just taking a moment to talk though also about the growth that we're seeing. So we currently have 44 brick and mortar OTPs. This is a 51% growth since 2018. We also have 12 tribally owned and operated OTPs, the most in the United States at this time. We have 16 mobile opioid treatment programs, also the most in the whole country by a lot. And I want to say this number of 16 is in addition to the 44 sites that are above. And then also we do have that one medication unit that is currently opening, that is a fixed site, and another 3 there. We also have like another at least 2 to 3 OTPs that are expected to come online this year, and then early 2027 in Wenatchee, Walla Walla, and Holsbo. And back in 2023, when I had presented to SURSAC, we had pulled information that showed there around like 14,000 OTP patients. And right now, as per the OTP providers, and this number is regardless of payer source, this is not just Medicaid, we believe the OTPs are currently serving over 19,500 Washingtonians and growing. So as you can see, like, there's just been this kind of explosion, very well needed, in methadone access. And we haven't even still hit like all the areas that we need, but also demonstrating why some of the SURSAC recommendations that resulted in directives have been successful. And then also the need for like resources is still there because, again, there's a lot going on in this space. And I know I had just actually talked about recommendation 3 a bit again, and it talked about the public hearing. Another thing that was important is there used to be an RCW prior to 2023 that used to say a county legislative authority could actually cap the total number of patients in an OTP at no less than 350 people. So like any OTP could have up to 350 people, or then a county would have to approve if they could serve more. And while we were not really hearing counties implementing and like enforcing this cap, a lot of discussion at that time was around, is this really a helpful, important thing? Will we cap the patient census for any other healthcare setting? So SURSAC had recommended also at this time, let's get rid of the cap. And the legislature took those recommendations from SURSAC, and yes, they changed it. So there is no longer a cap, and no city or county legislative authority can impose a maximum capacity at an OTP program. That is what became the RCW 24590 language. And part of that change several years ago was directly from the SURSAC committee and the recommendations that this group brought. So, and then I think this rest of these slides here, we're just specifically, again, talking about that quality improvement opportunity where there was no funding or directives in alignment with the previous SURSAC recommendation to try and educate both communities and elected officials on OTPs, MOUD, methadone, zoning things. And again, some of that previous discussion we were just having as a group. But I'm going to pause here and see if anyone has any questions or comments about this. Addie.
Thanks for this great presentation. Thinking back to the communities that you were mentioning where maybe they've never had an OTP before, and somebody wants to open one, what have you found to be the most effective strategies in terms of educating both legislators and the community?
You know, our state has state requirements already through Department of Health that requires the opioid treatment programs to all be engaged with ongoing community relations, where we actually put the provider as responsible for educating community partners. And Department of Health even has a template community relations plan that talks about, you know, an OTP should be meeting with local emergency services, talk with your local police and fire departments. Are you talking with other social service and healthcare providers? It helps you to hopefully build relationships for referral entities, and then also just to build support and consensus in the community, talking with like local groups, whether it's like a block club in the area where you're opening. It could be talking with a business association that's in the area you're trying to open. It also asks for the OTPs to demonstrate that they have successfully connected with city and county legislative authorities. So that requirement has been kind of helpful to build consensus at like a very local level where the provider that wants to expand is kind of responsible for doing that. But I think the connection with elected officials, again, the only thing that's seeming to be effective is when either state officials like the SOTA team, my team, Opioid Treatment Authority team, or the Attorney General's office reaches out to elected officials in certain areas where there are zoning issues and says like, hey, just so you know, you actually could be breaking a ton of laws and like this could be a risk factor for you. And thankfully, it's never gotten to the point where the Attorney General's office has had to more directly engage with local places. But I don't know. I guess my question, maybe this is a non-answer. I just don't know if this is the most effective thing that could be done for this. And I feel like, again, this SURSAC group in the past had recommended just, again, if there was ability to do more like local campaigns, official information sharing channels, would things be like more effective with both building consensus and information to empower like local communities and city and county legislative authorities to view things differently. So I know it's kind of a big non-answer, but again, there are some strategies that are working, but it just makes me always wonder, like, is there something else we could be doing that would be more effective or basically more proactive and not waiting for a problem to emerge for there to be then more attention? I'm also seeing first Caleb, maybe.
I just want to make sure folks know there are some resources on ADAI's webpage around this, and we'll also be releasing more syringe service program client data over the next month or two. But the preliminary data, when we ask folks who are using opioids, what would they want if it was free and easy to get? Methadone is very high on the list. Buprenorphine is actually a bit lower, and so folks are aware. As I understand, not being a medical provider, there are some reasons that methadone may be particularly attractive and effective for folks who are using fentanyl in particular. So there's a lot of reasons besides access to care and methadone. There's also some things about the drug market and what drugs are out there that make methadone a really important medication to make sure people have access to. So we're always happy to share information if there's any data that we can provide. If people do want to do education, excuse me, I almost said advocacy, education with anybody, we're happy to share some of the data that we have and or point people to that. I know that data don't necessarily drive policy, but where we can provide backup information, we're happy to do that.
Thank you. And I saw there was a question in the chat. What about in Lewis County? And a comment about some things where local elected officials in Lewis County were making it quote unquote difficult for one provider having to even sue them. And I just want to say, yes, Emily Curio's answer is correct. That agency down there in Lewis County was not an OTP, but there certainly are a lot of similarities in context of what we're talking about, just stigma, lack of information, and then sometimes local counties and cities issuing policies, maybe they're not the most informed with like evidence-based practices and what is legal and what is not at times. And again, I think the goal is how to help communities make the best decisions for themselves, but then to be able to make more educated decisions when these topics are so complicated, and how to connect them with the knowledge that there are entities at the state level, like the Attorney General's office or the State Opioid Treatment Authority office or Department of Health, who can answer questions for local officials, so they can again make their own best policies for their communities. And just moving forward, super excited. This speaks back to one of the questions Malika had asked. One of the recommendations that came from this group years ago is, could we fund capital construction costs to help support the startup of OTPs in specifically Central and Eastern Washington, where historically there's only been one OTP in Tri-Cities, one OTP in Yakima, and a couple out in Spokane. So we talked about, this SURSAC group had talked about Department of Commerce had, historically been given money. It helps with capital construction costs, like Caleb Bantagreen was mentioning in the beginning. These are high cost settings to build because you have to have like a counseling space and medical spaces and a dispensary, and it has to be DEA grade. So some of the expansion concerns and costs have just been, they cost a lot to start up, and like moving into a rural area where maybe there will be a lower census overall, it's harder to expand. But what happened from this recommendation is from SURSAC, the legislature used that in part to make decisions to say, like, yes, we are going to provide funding to increase the number of mobile methadone units in our state, to prioritize specifically rural areas, and also to increase the ability for there to be methadone, fixed site medication units, and other OTPs. So this came about back around 2023 with 5536. We were successfully at the Healthcare Authority able to release in tandem with Department of Commerce. We both released the first of its kind RFA bid, where both Commerce and the Healthcare Authority put funding in to award contracts specifically to help build OTPs in a rural part of the state. And I am so happy to say we were able to award a contract to Acadia Healthcare, and they have built an OTP in Wenatchee that is set to be opening reportedly by April of this year. We also still had money left over from that, so we did a second RFA. And we actually awarded a second contract to another organization, ORTC, that has built an OTP in Walla Walla, Washington, that also is going to be opening probably by early this summer. And then the Department of Commerce had their own set of funds, and they awarded a contract to the Suquamish Tribe of Washington that is going to be building an OTP in Poulsbo, Washington, that will probably be opening by like around January or hopefully early 2027. So all of that to say, when Malika had asked a question, what can be done to expand? This is one strategy that has been effective. When there has been designated funding specifically to increase OTPs in rural areas, and we limited the ability for applications to be just like you have to as an organization apply to build in specific counties and areas of the state that are only rural, it's working. So again, we're going to have 3 new OTPs coming online this year. And with these funding, because they're state funds, we've been able to also impel requirements, like they have to operate these buildings for a decade. And a lot of this is also opiate settlement dollars. So it seems like it's been a really good way to spend these one-time only funds to hopefully create like an ongoing legacy of treatment in things. And also a great way to say directed growth is possible. And we're very excited about this. So also it could present like cost savings to our state because we currently pay for non-emergency Medicaid transportation costs. But because many OTP patients need to go to a methadone clinic very frequently to pick up their medication, especially in the very beginning of treatment, or if they're struggling and need to come more frequently until they can stabilize. I believe OTPs account for between over 1/4 of the total non-emergency Medicaid transportation costs for our entire state. So we have people who've been traveling like 2 or 3 hours via a paratransit just to get methadone dosing like every day or a few times a week. That's cost that adds up, and that's been significant. So in addition to helping to serve people, which is right, the morally correct thing to do, the ethically correct thing to do, what we're trying to do with getting more treatment access out there. It's also a huge cost savings to meet people where they're at and try and bring treatment to the communities where people are at instead of forcing people to travel hours a day just to get their life-saving care. So I'm going to pause here to see if there's any questions or comments about this, because again, we're very excited about all of this. Okay. And we're coming up on the very last one of the sub-recommendations. So back again, 2023, the SURSAC committee did talk about, yes, exactly what we've just been talking about. Providing funding to state agencies like the Healthcare Authority to provide a competitive bid process like a RFI or RFP, again, to establish OTPs in specific parts of the state. This was also specifically, though, for the medication units. Like, let's also try and promote these either mobile sites or fixed sites in our state, again, to try and meet people where they're at. I think the idea was a satellite clinic, again, is less expensive to build than a larger scale traditional brick and mortar site. So it might be also a better fit for a community that is more rural, and maybe there will be a smaller census footprint, and you would not need to serve like 1,000 people at a site, which some of our large urban sites are serving like 1,000 individuals at a site. But then maybe a fixed site might serve only like 150, which are still all important people in that community, but not need like a full imprint. So we again had used the funding to allocate funds. We had funding for a full biennium. So we were planning at the Healthcare Authority to basically use this biennium to take that Wenatchee and Walla Walla site and expand fixed site medication units off of those sites to like build these satellite clinics that legally have to be connected to a main site in these same kind of rural areas, just like expanding outward. But during the 2025 legislative session, there was budget proviso language for this specific workflow that changed from the language that had been in the previous biennium. And this change in language did end up having an impact. So I've included the older proviso language that had passed that kind of was more loose and just said the state agency would increase the number of mobile sites or fixed medication unit sites by existing providers and to expand with a prioritization of rural areas. But then last year, the language changed to the appropriation is provided solely for the authority, the healthcare authority, to provide treatment services through the new providers that were funded in basically this setting. So what does this mean? We had a lot of conversations with budget around the budget forecast and the proviso language with representatives from like the Senate Ways and Means Committee. And we heard that basically we could not use the funds to support fixed site medication unit expansion, meaning like paying for capital building costs or other costs to support that fixed site expansion. But instead, the healthcare authority must use all of that money to support the non-federal share of Medicaid services. So what that means is the directive is these new sites in Walla Walla and Wenatchee will be serving Medicaid patients. And we are now going to be using the opiate settlement dollars to, again, pay for the non-federal share of the medication service. So we were totally about to sign contracts to expand more fixed site medication units, but then we've had to hold that and kind of end all plans to do that based on the Senate Finance staff's clarification. And also, we did provide feedback, to the Senate staff that OTP services are baseline a Medicaid eligible service. It is something that's already required to be covered by CMS in all US states, and that already would traditionally be covered by like the state's general funds and the Medicaid budget. But we have continued to get feedback that no, this is correct. We are at the Healthcare Authority need to support the non-federal share of the Medicaid service delivery at those sites. So we have taken that feedback. And then we also had shared a little bit of information like these two sites won't be open until midway this year. So there could be a chance we're not going to spend down all the funds because we're not sure, both with them opening up and then building up a patient census, will there be enough Medicaid service delivery to draw down on that full amount between the two sites? But anything I think that will be not spent might be swept back. And again, ultimately, I was wanting to share with this group that again, the SURSAC recommendation was do more of using the funds to expend capital, but we have been directed to spend the biennium we're in now, like this year's set of funding, just paying for the Medicaid services. And we're having ongoing discussions even around like making sure there's correct federal match being applied because the funding directives for the last biennium and this biennium have changed. So there might be different match implications on things. So I know this is kind of like way in the weeds, but I also know there are a lot of like elected officials and things on SURSAC, and this one might be of particular interest to folks. But I'm going to pause there and see if there's any questions. Okay. I know I'm running way up on time, so I'm going to be wrapping it up here. This is not part of SURSAC, but I thought it'd be helpful just to mention. There is the Rural Health Transformation Program, which was implemented when the H.R. 1 federal budget reconciliation bill passed, and it provided around $50 billion funding nationwide through CMS to award states funds to help support rural healthcare providers that would be impacted by H.R. 1. So right now we know CMS has awarded Washington State around $181 million for year one of its program. And the funds would support like hospitals, clinics, all different types of providers in rural communities. What we wanted to raise awareness of here is that HR 1 legislation actually specifically called out OTPs specifically as one provider type that can get these funds. So when Healthcare Authority applied to CMS, we did actually apply and say we plan to use a subset of the funds just to help support OTPs specifically. And because we know one of the biggest issues for rural health expansion is workforce recruitment and retention issues. And again, OTPs have that treatment team. It's really diverse. They have prescribers and nurses and counselors and other support staff. So it can be hard for them to staff up in rural areas. We are going to be having a competitive bid process to spend down the OTP subset of funding amongst rural OTP sites, specifically focusing on supporting workforce recruitment and retention. And we do have a goal, really. It will be a competitive bid process, but any OTP that can meet the state and federal requirements to receive the funding, and that also happen to be located within a rural area of the state, or can demonstrate that they're serving a significant majority of their patients from a rural area, we want them to be able to get the funds. So we do have some language that's here. And then again, just some ending with some links. We do have our website at the Healthcare Authority around opioid treatment programs. We have a directory guide that lists out all of the OTPs in our state broken out by county. We're talking about all this expansion. It's a helpful thing to bookmark and share with others because you never know when an OTP might be opening up in your neck of the woods. The Department of Health website on all the licensing and certification requirements if any organization is looking to partner with an OTP to expand. Our state healthcare authority's Rural Health Transformation Program website, and then also some of the work we've been doing with the Attorney General's office to create campaign materials for patients who are taking medications and knowing their patient rights and that they should not be getting discriminated against by either healthcare settings or really any setting type. But and then this is just an example of what our OTP directory looks like. This is a map kind of showing where expansion sites are now. As you can see, we still got a long way to go to expand into many parts of central, eastern, and rural Washington. And then again, our guide is broken out by county. But I'm going to pause there and take any last questions or comments, but then this will kind of also conclude my formal part of the presentation today.
Any questions for Jessica? All right, Jessica, thank you so much for the great information. Appreciate it.
Thank you.
Yeah, take care. Thanks for being here.
Jessica, if you haven't yet, take a look at the chat also. There's lots of great feedback for you there.
I will definitely do that. Thank you so much. And again, thanks for the opportunity. And thank you to everyone who's been involved with SURSAC. I hope today is a great example of this work has been meaningful and it's driving real change. So just thank you all for your participation with this and everything you've done to help support OTP expansion in our state.
Awesome. Okay, next on the agenda, SURS plan elements, status overview. Tony, anything to mention before we get to Michelle?
No, just extending appreciation to Jessica and Lauren and the SOTA team for all the work done. Just wanted to point out as we kind of transition into this final agenda topic that Michelle is going to take us through, Jessica did a really good job of summarizing the sub-recommendations within the overall recommendation. And so as you know, with the way that the presentation was formatted, we had the overall recommendation, I forget the number of it, that was in the SURS plan, but it was really nuanced. It was really detailed with 5 sub-recommendations. And it took a lot of time to kind of summarize, and good time used, I'm not, it's not a critique, to summarize like how complex those sub-recommendations are. And so as a reminder, we kind of talked about this last month where we asked the committee, like, how do you want to spend this last year? We have through the end of December of 2026 before the committee sunsets. And the feedback that we received was we want an update on what aspects of the substance use recovery services plan are still outstanding or haven't been implemented. And so Michelle's been working over the past several weeks to try to figure out how to format that in a way that is helpful and beneficial and informative. And it's just a perfect segue from the update around opioid treatment programs. So I'll pass it to you, Michelle.
Yeah, thank you, Tony. And just to build on that, the past few years with our annual SURS plan progress report, what we've been focusing on are the elements of the plan that have received the action on a state level to implement them. And so for updates around all of those things, those annual reports are really helpful and thorough. What we want to do now today and at future meetings is go back to those original recommendations, dig into all the sub recommendations from those and see, which of those sub recommendations have not been able to move forward and be implemented, and then talk about what we can do to gain momentum in those areas, as well as recognize sub recommendations that have gotten the support that they needed for implementation. So as you can imagine, there's a lot of material to cover. We have 3 recommendations ready for review, but what we're mostly looking for right now is just to make sure that this format is helpful, and that if we continue to fill in this information, that the committee will find it useful at future meetings. So,
And
pulling that up.
while Michelle's pulling that up, just real quick, the amount of detail that Jessica just went into summarizing the 5 sub-recommendations related to opioid treatment programs, it's a little, when focusing on OTP specifically, it's a little bit different than talking about the continuum of housing. For the most part, OTP regulation oversight is within the SODA office and then in partnership with Department of Health. When talking about the continuum of housing, it's broad and it really touches on all of the state agencies. And so what we've been trying to grapple with is how to envelop the entire, breadth of services or work that's happening in a specific area across the state. Like if we only focus on what HCA is funding or what we have oversight of or what we've been involved in, it makes it a little easier. But at the same time, it's a little more narrow. It's not as broad of a summary. And so, just be kind of considering that, thinking about that in terms of how we can bring information to you for the next 10 meetings of the year. That some of these topic areas are going to get pretty detailed and intricate when considering all of the work that's happening at Department of Children, Youth, and Family, or Department of Commerce, or Department, Social Health Services. Okay, sorry.
Yeah.
Go ahead, Michelle.
Oh, yeah, thank you, Tony. And as much as possible, just to build on that one a little bit more, 5536 was a primary response to this plan. And as much as we can, as much as we have capacity to and awareness, we want to let you know where other efforts and initiatives are in alignment with the recommendations, even if they are not like a direct response to the recommendations or the plan itself, right? So as housing, there's investments in housing and these other areas, we want to let you know if there's progress, again, even if it's not coming from something like 5536 or a direct response to the plan. Anyway, all of that said, this is the outline for how we're approaching these. So we've got the short summary of a recommendation, a short description, and then in the table, we've got the proposed legislative action that, like the sub-recommendations, the specific sub-recommendations, and then whatever outcome has happened from that, or an immediate outcome. Under that table, additional implementation notes that are helpful to understand where things are at. And then under that, any links to SURSAC meetings that help provide more context around how that recommendation came to be, the conversations that have been had around that. So for this one in particular, this was our recommendation, the SURSAC committee's recommendation for the state's criminal legal response to simple possession. And there were several conversations around that. And so the meeting recording is there. And this is helpful, particularly for any newer members of the committee, if you're interested in how these recommendations came to be. There's links to those recordings in this document, so you can see that. And then additionally, follow-up meetings as well. So for example, there was a request for, looking at the research and data analysis on statewide drug arrest and charge data related to simple possession, to see kind of what the impact of this recommendation was, or the actual legislation that had been passed, really. And that was on May 5th, 2025. But in any case, I won't read through all of this, but you can see that's the basic layout is the recommendation itself, where possible, a link to the original drafted recommendation. That's not applicable here. Table of the sub-recommendations and the outcomes, and notes and meetings that are relevant. I'll just keep scrolling down so you can see another one. So recommendation 1, the financial incentives for recovery residences. Again, we see the legislative action outcome associated with it. This one also has funding requests. So any funding that was requested for implementation, whether that was received, where it was received. And then again, the SURSAC meetings related to any updates that have already been provided. So I'll just pause there. I think you can see kind of where this is headed. Any feedback that you have around whether this is helpful and we should do this for all of the recommendations. If we're missing any essential information, anything like that, please let us know now.
Yeah, Caleb, go ahead.
To me, this looks good, and I just want to note, I know it's probably 8 months out, but just as when, I can't remember if it was 3 or 4 years ago, when we had these recommendations for the legislature, there was an educational session held in the fall that the chairs of the various committees, including myself and other folks, presented to a legislative committee about this bill. So I'm wondering, as this wraps up, if we could do something again this fall in preparation for the next long legislative session about sort of this wrap up and potential next steps. So I know we can't do anything about that now, but that also seems like something to consider for the fall. Thanks.
Yeah, I made a note of that. We'll, once this current legislative session is over, we'll connect with our legislative affairs and analysis team and kind of float that idea. And but yeah, that's a good reminder. I had forgotten that the subcommittee chairs had met and did that kind of legislative symposium. So thanks for bringing it up, Caleb.
Okay, we may have time for one public comment. We are approaching the end of the meeting. Any call for a public comment? If you're a member of the public and would like to make a statement or ask a question, please go ahead and raise your hand virtually. All right, last call for public comment. All right, Tony, you want to wrap us up?
Yeah, and just thinking more about what Michelle was summarizing, and again, we're looking for feedback from the committee about how best to structure future meetings and to focus and hone in on some of those specific recommendations. So please feel free to reach out to Michelle with any kind of feedback. It sounds like for the most part that format is going to be helpful. I'll say when we can, we will bring in a guest like Jessica or somebody that's more closer to some of the specific work and maybe provide a presentation like Jessica did. I think that was really informative and helpful. And we'll continue to do this, in partnership with other committees and other groups in the state that are working on these similar issues. We have the State Opioid and Overdose Response Plan Learning Collaborative that is also discussing a lot of the efforts under the State Opioid and Overdose Response Plan that Chris Shira is leading. And then we also have the Behavioral Health Advisory Council that meets quarterly. That's that's a requirement under our SUPTERS block grant, Substance Use Prevention, Treatment, and Recovery Services block grant. And so some other parallel efforts, even with the Children's Behavioral Health Work Group. And so to whatever extent we have capacity to do so, we'll try to bring in some of those other experts and other work that's happening across the state to try to inform the updates as they relate to the Substance Use Recovery Services Plan. And I know we have 5 minutes left, but I'm not sure Chris is actually here with us today. Chris, if you wanted to provide any kind of ad hoc updates on the opioid abatement settlement work or the state opioid and overdose response plan.
I did just want to note that we're actually going through the strategies tables and have been working on updating those. Some folks are familiar with that. The current iteration of the plan has about 35 pages of those strategy tables. It's good to know everything under the sun that we're doing, but it doesn't necessarily make the plan accessible, or it doesn't really highlight what the priorities are. So we'll be taking that out, but we're still updating them. And so that's something that you might hear about at some of the State Opioid and Overdose Response Plan work group meetings coming up. I'll be announcing that work and sharing with everyone the process for getting that updated. In terms of opioid settlements, we're just watching the budget process as everyone else is, and we did receive a couple of new items in the governor's supplemental budget. One was $600,000 to support tribal opioid response task force and summit activities, as well as some funding to support opioid treatment program accreditation and certification costs. Those were the only 2 new things. Basically, everything else remained. There were some funding shifts here and there, but everything was budget neutral. So no other updates. I know we're just about out of time.
Thanks so much, Chris. And I mean, I think it just points to like how much work is happening across the state in different areas. And so it just does kind of add to the complexity of bringing like a fully exhaustive update on efforts made towards things like housing or things like recovery residences. But we will continue to work on it, continue to update the document that Michelle presented. And so I do encourage the committee members, please take a look at that, start to look through the recommendations and all the sub recommendations, because it does get pretty detailed. And we will attempt to bring back updates, either like one recommendation at a time or maybe a couple in each further meetings that we have through the end of the year, with the end goal of being submitting our final progress report. We've been submitting that progress report every year at the end of the year. We got the correct link in the chat today for the 2025 one. And so for the 2026, the final progress report we'll be submitting, we'll be able to highlight things like what Jessica pointed out in terms of like, there's still an opportunity for public education and community outreach to help support the continuum of services and methadone access and OTP access in the communities. And so we can highlight those sort of things within that progress plan for 2026, the final progress plan that we submit. Okay, I made it a point to try to get us through to the exact last minute of the meeting, and I succeeded because didn't want to leave any time for somebody to, no, I'm kidding. We ended early last month, so that was making up for the ending early. We don't have time to talk about the March meeting, however, so that was an oversight on my part. Didn't think about that. However, we will send out a draft agenda like we always do to the committee, and we'll get a final agenda sent out through Gov Delivery to all of our attendees and guests that attend, as well as on the SURSAC webpage. Michelle, anything else I'm missing?
I don't think so.
Okay, thanks everyone for your patience as we dealt with the technical difficulties. Huge shout out to Melissa Tomke for getting us back on track with our conference room tech support. And appreciate everyone's time today for the past 2 hours, and we'll see you in March.